Our next speaker before Dr. Edwards is Dr. Tiffany Wright. Dr. Wright is a native Kentuckian, grew up in Webster County, went to Murray. We were lucky to have her come here for medical school. She was one of those medical students who was always around. And then she became one of our residents, and she was always around. And I think she thought she was going to go back to Webster County and do private practice. Or maybe I was going to get her to be a trauma surgeon, but that was slim. And then sometime late, like fourth year,
July, 5th year,
she decided to do pediatric surgery. So then she couldn't go straight into pediatric surgery at that point. She went to the University of Michigan and did fetal surgery for a year. Then did pediatric critical care, became boarded in pediatric critical care. And then Louisville was lucky to recruit her there as their fellow. She did 2-year pediatric surgery fellowship at the University of Louisville and now has joined the faculty at U of L. So it's great to have her staying here in Kentucky. I really wish she was here, but an hour and a half away is almost as good. So Tiffany, thanks for joining us. Tiffany was one of those folks who got to be a medical student, gathered around in a group outside Dr. Schwartz's office waiting for him to come and do the almost daily teaching sessions. So I know she remembers those days very fondly.
Thanks for asking me to come. I only got the privilege of having Dr. Schwartz around for my first 2 years of residency, but loved him very much. And I have a feeling that if he was here right now, he would not be super excited about talking about non-operative management of appendicitis. So here's my disclaimer. I am not advocating for non-operative management of appendicitis. I think it's stupid, and if I show up with appendicitis, please just take my appendix out. But it's becoming an increasingly relevant topic, and I think it's important for us to talk to patients to know kind of what the data says about it. Appendicitis is the most commonly performed emergency general surgery procedure. It's important in my life and the acute care surgeon's life because it kind of bridges both of those age groups. About 30% is perforated at presentation, and that's not what we're talking about here today. And it's typically more severe at the extremes of age, probably because it's delayed in diagnosis. So for all of my medical training, management of uncomplicated appendicitis was not controversial. You take the patient to the operating room and take out their appendix. The same is not true of complicated appendicitis. There's always kind of, should you operate, should you drain it, should you treat it with antibiotics, whatever. But this non-complicated appendicitis controversy is somewhat new. It's now all over the news. I was on vacation at the beginning of my fellowship and was watching the Today Show right around the time that one of these studies we'll talk about came out. And they were talking about it on the Today Show. Hey, now you have appendicitis, you don't have to have surgery. So I think it's important for us to know about. So there's been some people looking at non-operative management of appendicitis since like the 50s, but the real studies, the big studies started coming out in like the mid-2000s, and mostly in Europe. So this first one, they wouldn't allow them to randomize to put women in the study, so it was just men. And they randomized them to appendectomy versus non-operative management, and basically found a 14% recurrence rate at 1 year with no significant difference between hospital length of stay and time off of work. These were all, for the most part, open appendectomies. 8 of those 124 patients had laparoscopic surgery. The second big study a couple years later, again, found that about 22% of patients had recurrence at a year. The complication rate in this study, also in Sweden, was much higher than I would expect. They had 10% major complications. Now, these were, again, almost all open appies, but they had 9 postoperative abscesses, 4 bowel obstructions, 5 reoperations, including 2 hemicolectomies from malignancies in the specimen, which they count as a complication, but it almost seems like a win for the surgical arm, right? I mean, if you had cancer in your specimen and you treated it non-operatively, that would be a problem. They had a really high rate of perforated appendicitis in this study. They didn't talk about how they made the diagnosis, whether it was just clinical diagnoses or whatever, but I think there were a lot of perforateds that made it into the study. So the real big study, in adults anyway, was the APPAC trial that came out in 2015 in JAMA. They enrolled 530 adult patients and randomized them to either 3 days of IV ertapenem, so 3 days in the hospital on IV antibiotics, followed by 7 days of outpatient antibiotics, versus, again, mostly open appendectomies. They found that they set a pre-specified non-inferiority margin of 24%. So if there was a less than 24% one-year appendectomy rate in the non-operative group, they would have called that a success, and they did not meet that. But what they found was that basically a 20% overall complication rate. Now, 23 of those 24 surgical site infections were superficial wound infections. And then these 23 patients with chronic abdominal pain never had any proof that they had any sort of a real problem. They just had chronic abdominal pain that they were attributing to maybe adhesive disease. But in the non-op group, 27.3% ultimately had their appendix taken out. So just a couple of last month maybe, the APPAC trial published their 5-year data in JAMA, looking at the 5-year follow-up rates of these non-operatively managed patients. And you can see that it goes up a little bit every year and is up to, at 5 years, 40% almost of patients. And their conclusion says, this long-term follow-up supports the feasibility of antibiotic treatment alone as an alternative to surgery for uncomplicated acute appendicitis, which I think is fascinating. We don't accept a 40% failure rate anywhere else in medicine. But I guess it's just your perspective. I mean, I guess if you really want to avoid surgery and you're comfortable with that. So all of those studies were done in Europe, and I don't think there's a whole lot of interest in non-operative management of appendicitis in adults in America, but the pediatric surgeons love it. One of my partners says that pediatric surgeons are constantly trying to non-op ourselves out of a job. But it's hard to get prospective randomized trials done in kids. So this is a meta-analysis that was published in JAMA Pediatrics in 2017 that looked at 5 studies that were all prospective, but only one of them was randomized, and it was very small, so it's mostly just prospective case controls, where they had 404 patients total, and at 1 month, 90% of the antibiotic-treated patients were better. But again, their failure rate at a year was about 27%. Of note, the subset with an appendicolith was significantly higher. There was the one study that was included in this that had an appendicolith. They actually stopped enrolling early because the failure rate was so high. The cost was less in the non-operative management arm. The stay was shorter in the surgical group. Now, these patients were all laparoscopic appendectomies as opposed to the older adult studies. And their mean time of disability was shorter in the antibiotics group. So one of the things that I think we all worry about is, well, what happens when they recur? Are they sicker when they recur? And all of those previous adult RCTs would say no, that the complication rate when they recur is no higher than if they had had it the first time. But this is a meta-analysis that was done of those studies with larger patient numbers, and they found that the rate of complicated appendicitis with perforation at the time of surgery was significantly higher in the antibiotic group. So 19.9% of the patients presented with complicated appendicitis compared to only 8.5% of the people that were initially treated with surgery. And there was no difference in this study of the huge meta-analysis of the post-intervention complications, length of stay, period of sick leave in the surgical versus non-surgical group. So one of the other arguments that people often use for treatment of appendicitis with antibiotics alone is cost. So this was a retrospective review published in the Journal of Pediatric Surgery in 2017, looking at the cost of non-operative management to the cost of lap-appy. The initial length of stay between the two groups was similar, and the initial cost of the two was significantly higher with appendectomy, but the recurrence rate was 35%. So when you include their subsequent care related to their recurrences, the total hospital cost was the same between the two groups. And the total length of stay was actually higher in the antibiotic patients. So everybody's always talking about, patient and family-centered medicine, letting them sort of help make the decision. So what do the patients want? Pete Minichi at Columbus is really into all of this patient choice stuff. So he did a prospective patient choice cohort study and enrolled 105 patients and let basically the kid and the parents choose whether they wanted surgery or antibiotics.
And where did they go about it?
I don't know. Did he go to?
The families.
Oh, right. Yeah, correct. So non-operative management was initially successful, again, in about 90% of them, and again, at about 1 year, 25% of them had failed. The non-operative management group had a slightly longer length of stay. Whether or not that difference is clinically relevant, you could argue. This study quoted a post-op complication rate that was lower than those adult previous studies at 7.7% at 1 year, but most of those complications were really minor. The only two that they considered major complications was one readmission and one patient that got a reoperation, but it didn't say what for. The health-related quality of life scores that they asked the patients and the parents to fill out at 1 year were similar between the two groups. We're currently participating in the follow-up study to this, so it's a multi-center, again, patient choice study. So we've been enrolling patients for, I did it in Michigan and have been doing it all the time I've been at Louisville. And most patients do not choose antibiotics. We've actually had to increase our enrollment targets to get to the threshold of enrolled antibiotics patients. I think it's probably like somewhere between 20 to 30% of patients actually choose antibiotics. This was a web survey published in JAMA just not long ago, where they asked 1,700 people. They gave them some information, some scenarios on laparoscopic appendectomy, open appendectomy, and antibiotic treatment alone. And they asked what they might choose if they or their child had appendicitis. Most of the respondents were female, and most of them were sort of 30 to 60 years of age. Most of them chose lap appy for themselves, and a small number chose antibiotics alone. Interestingly, for their child, more of them chose antibiotics alone and not surgery. I thought it was interesting how many people chose open epi. They were more likely to choose antibiotic alone if they had postgraduate education, which is, I think, also interesting, or if they knew no one who had previously had appendicitis. 11.9% of the people in this survey were surgeons, and 100% of them chose surgery. But like 10% of them chose open epi, which, again, I think is fascinating. I would not choose an open epi. So what are the hesitations to widespread adoption of this? Personally, concerns about progression to complicated appendicitis. My first month as an attending, I did 2 laparotomies for bad ruptured appendicitis, and it was maybe the 2 most miserable cases of my life. The burden of worrying about recurrence. So every time they have belly pain for the rest of their life, are they going to think that it's appendicitis? Are they going to come in and get another CT scan? All of these previous studies have someone who had a tumor in their specimen. So there's that. 50% of carcinoid tumors of the appendix, I think, present as acute appendicitis, and it may be hard to delineate that on your preoperative imaging. One of my biggest concerns is that all of this now is becoming really widespread in the pediatric literature. It's in like JAMA Pediatrics. So similar to what has happened in a lot of places with small bowel obstructions, when we decided to stop surgically managing, to non-operatively manage bowel obstructions, they started getting admitted to medicine doctors in a lot of places. So I worry a lot that, pediatricians and general internists are going to start treating patients with antibiotics for appendicitis without getting us involved. And still, the overwhelming majority of patients and parents still don't want it. One of the things that's sometimes quoted is that the reason that we're hesitant to adopt this is because we get paid to take out appendixes, but maybe it's because I'm on salary, but I don't think that this plays any role in most people's decision-making. Finally, I don't know if any of you all are tennis fans. I am not, but I've been told that Rafael Nadal had appendicitis, and it was like in the middle of a season, and they treated it non-operatively with antibiotics, and he sucked for like months because he was, still on all these antibiotics, and then they took out his appendix, and now he's better and back and whatever. So if anybody needs to use that as an example.
Dr. Wright, there's a lot of really interesting numbers there. The data is interesting. A couple of interesting things that I saw there was the look at cost. We've presented data from here showing we can save about $1,000 on the hospital admission if we just send them home from the PACU. So I think there's a way to drive down the surgical costs.
Sure.
I'm interested in what you guys do with kids there with regards to going home from the PACU or short stay. My second question is about health literacy. So the most educated folks are the ones who were saying, give me antibiotics, and that might work for them. But, health literacy is poor in Kentucky, and sometimes that's a chance to eradicate something that could be very dangerous in a child in a culture where health literacy is not that good, and that kid could be at risk going home if we're depending
Sure.
upon family members to pick up when the kid gets sick. Can you comment on both of those?
Yeah, so we typically admit them post-operatively and then tell them if they feel like going home, a few hours post-operatively, they can. I think in general, parents' thresholds for how much suffering they're willing to take a child home with is much less than what gallbladders we a lot of times admit because they're not a little nauseated and their pain control's not great, and the moms invariably would have them back in the ER if you tried to send them home like that. But occasionally we have some people that go home a few hours post-op, but most of the time they stay till the next day. With regards to that big prospective study, that multi-center that we're participating in, the cities that typically have better educated populations have had much more success enrolling patients in the antibiotic arm. And when I go down and talk to somebody, I try to be like as unbiased as possible, and it's kind of hard. But they actually have to take a quiz afterwards about whether or not they felt like you were swaying them one direction or the other. But it also goes along a little bit with the anti-vaccination stuff. So like in Ann Arbor, where everybody's really highly educated or whatever, there's so many people who don't vaccinate their children, which I think is crazy. But they also don't want surgery for their appendicitis. Yeah.
Sorry. In your study, how are you making the diagnosis of appendicitis? Is it like ultrasound, physical exam, or how?
So the one that we're doing right now,
Yeah.
they have to have imaging that says that they have appendicitis. But our actual criteria for enrolling patients is so stringent that I think a lot of them don't actually have appendicitis. And could still qualify for the study. Their white count has to be less than 18,000. They have to have had pain for less than 2 days. They can't have a fecalith on their imaging, and their appendix can't be bigger than like a centimeter. So I see patients all the time that would meet that criteria, that when I examine them, I'm not really sure they have appendicitis. I admit them, hydrate them, and the next morning they're better, and we send them home with no antibiotics and no surgery. So many of my partners that refuse to enroll people in this study argue that it needs a third arm, one where perhaps you did nothing, because maybe it's just a self-limited viral infection and not truly appendicitis. And clearly, if you treat those people with antibiotics, they're going to get better.
Other questions? Dr. Wright, Dr. McGrath?
Hello, sir.
Is there a subset of patients that you would not immediately go in on?
That I would not immediately operate on? In uncomplicated appendicitis? If I didn't think they had appendicitis?
Uncomplicated appendicitis. So complicated, you would not go in on?
We're pretty aggressive with operating on complicated appendicitis, honestly. We have a pretty poor IR availability, and so that's why my two first cases of my first month of attending life, I ended up doing like laparotomies, and one of them I couldn't even find the appendix. It was a mess. I was going to have to give him a colostomy, I'm pretty sure, to like find it, so I just drained some pus and got out. But we're pretty aggressive with operating on even complicated appendicitis kind of from the get-go, unless they're well appearing with a really big, well-defined abscess that you could hit from across the room. And they're kids, so most of the time they get better.